Hello everyone, this is Renee Diaz and I will be your instructor for geriatrics. Geriatrics is defined as 3 different stages of the elderly. The first stage ranges from ages 65 to 75, and that is considered to be the young old. The next stage is 75 to 85, and this is just simply considered as old. And then 85 and older is called old or the oldest old. Okay, so this is just an overview of what we're going to cover in this voiceover. The first topic we're going to discuss is health-related changes and common health issues with this population. Next is safety issues in the elderly population, and there's a lot of those. Then we will move on to aging in place and alternatives, and finishing up with immunizations for this developmental age. We are starting with health-related changes and common health issues. As you can see on the left hand of your slide, it goes over the different body systems and organs. And you'll also see that dementia is at the end because this is a common change and common health issue that we see with the elderly population. Continuing with the health-related changes and common health issues, we're going to start by discussing normal aging change or typical aging changes that you're likely to see in an elderly client. We're going to start with cardiovascular. It is typical to have a decrease in cardiac output and an increase in peripheral resistance and systolic pressure. So to assess your clients, you want to focus on their activity intolerance, their blood pressure, including if they have any orthostatic hypotension. And you want to assess for any arrhythmias, so making sure that you do a full minute of the apical pulse is very important. Moving on to respiratory, it is likely that the elderly person has a decreased elasticity of the chest wall, and they also have a decrease in intercostal muscle strength and a decrease of cough reflexes. Typically, the diameter of the chest wall will increase, and so will the rigidity of the lung tissue. So when you're assessing your elderly client, you want to assess for the cough reflex or any accessory muscle use and gas exchange or pulse ox, in addition to assessing for any mouth breathing that may occur when you're assessing the client. Next is neurological. Typically, there is a decrease in nerve cells, and neurotransmitters are often decreased and slower. The amount of REM sleep has also diminished, and the blood flow to the central nervous system has diminished. So as nurses, we can assess for their reflexes to see if they've started to decline. We can get an idea of their sleep pattern by asking them how much they sleep, the times they sleep, and asking them if they feel rested when they wake. So now moving on to GU. Often there will be a decrease in the glomerular filtration rate in the kidneys. The blood flow to the kidneys is often not that great. And again, this is because of that decreased cardiac output, so they really go hand in hand. Their bladder capacity is decreased, so sometimes there will be some incontinence problems. There is a decrease in vaginal lubrication and also a decrease in hardness of erection. So as nurses, we're going to assess for their continence, any urgency, frequency, or again, if they're having any accidents. We also want to assess their hydration status. We want to make sure that they are still drinking well. And a key part of this, and we'll get into this a little bit later in the lecture too, is to assess their drug levels to make sure that they're at a therapeutic level and not a toxic level. So if they have a decrease in their filtration rate in the kidneys, they may also be holding on to medications and not excreting them at as fast a rate as some of the younger people may. So their drug levels may become toxic very easily. Additionally, you should assess their sexual patterns and see if they need any medical assistance in that area. So for GI, typically there is a decrease in saliva production, a decrease in GI motility, so the movement in the gut, and a decrease in gastric acid production. So assess their ability to chew food and assess their elimination pattern. How often, the consistency of bowel movements. We also want to assess the frequency and size of their meals, so a 24-hour food log may come in handy here. We are continuing on with normal aging changes. Next is musculoskeletal. It is likely for the client to have a decrease in muscle strength, body mass, and joint mobility. And they will also typically have an increase in fat deposits. So assessing them, you want to assess any activity, any exercise and tolerance would be appropriate as well. Assessing for any joint pain and assessing range of motion, both passive and active. Their gait, balance, posture, and change in height should also be assessed. and their susceptibility to falls. So we want to make sure we are doing fall risk scales on them. We also want to assess their ability to perform ADLs, making sure that they're still able to care for themselves, and if not, that they have the proper services in place. Moving on to skin, they often have a decrease in skin elasticity and a decrease in nail growth, and the nails can also be brittle. There is an increase in the dryness of their skin, thinning of the skin layers, so you'll notice that you can often see their vessels under their skin very easily, and they're also very prone to skin tears as well. There may be nail thickening, if not brittle nails, depending on their diet, and hair thinning is also common. So assessing for their susceptibility to hypothermia is essential with the thinning skin. You want to assess for intact skin and bruising because remember, they're more prone to having these skin tears. Moving on to endocrine. So with the endocrine, the elderly client typically has a decrease in insulin resistance, a decrease in thyroid function, and also a decrease in either estrogen or testosterone levels. So assessing for changes in weight, if there are changes, if it is increased or decreased. We want to assess their energy level. We also want to assess their libido or sex drive. So for sensory, typically there is a decreased visual acuity and depth perception. There is a decrease in tear production along with diminished pupil sizes, so they're not able to acclimate as well. Their sense of smell and taste decreases, and their hearing of high-frequency sounds can diminish. Their sense of balance can also change, and their pain sensation changes as well. There is an increase in glare sensitivity and thickening of the lenses of the eye, so they're not able to adjust as well, especially with fine print, and that's where you'll see often reading glasses come in. So as nurses, we can assess and make sure that there's adequate light with a glare-free bulb, assessing for home safety. We also want to assess their driving ability if they are still driving, but we will get into that a little further when we go into the safety portion of this voiceover. So on the previous two slides, we went over normal or typical aging changes. Please note that dementia is not a normal process during aging. It is a disease that typically affects the elderly population. It is an umbrella category, so you'll see the different types of dementia are listed on the left-hand side of this screen. This is a progressive cognitive decline, and typically a patient with dementia will have a memory impairment and one of the following subcategories. So in addition to having the memory impairment, they may have aphasia or the loss of ability to communicate with others, or they could have apraxia, which is the difficulty carrying out purposeful movements, or agnosia, which is the inability to recognize objects and can also lead to the inability to recognize family members or people they once knew very well. It is a disturbance in executive functioning, which means like carrying out ADLs such as paying bills or making sure to schedule doctor's appointments and actually following up with them. Because remember, they have this memory impairment and inability to recall certain events they need to follow up on and the inability to communicate. It is typically very difficult for them to remember things, think clearly, communicate, or take care of themselves, especially in the later stages of dementia. It can cause mood swings, changes in personality or behaviors, which can be really difficult for the family members around them to cope with and still be supportive of someone who is suffering with dementia, with those mood swings and personality changes. So to further elaborate on dementia, the most common form of dementia is Alzheimer's dementia or Alzheimer's disease. And the risk factors for this include old age, which is why we are covering it in this lecture, family history of the disease, cardiovascular disease, and any environmental factors, especially any head injuries or alcohol abuse. Again, please note that delirium is not dementia. They are two different things, but they often get misdiagnosed or confused. Delirium is a short-term acute loss of some of the cognitive abilities that you will likely see with dementia. So to further understand the differences between delirium and dementia, the table in one of your textbooks that I highlighted on your slide goes over it very clearly. Okay, so now we're moving on to safety, and of course safety is a priority for any developmental age. Physical safety and polypharmacy concerns are very common for elderly clients, and protecting them from abuse, and also making sure that their psychosocial transition is okay, as they are making a transition from younger adult to older adult, and this really is a process. In this slide, we're going to talk about physical safety. The first category in physical safety is falls. Their motor strength and just their muscle mass overall and their joint mobility is typically decreasing. If you remember, this is a part of normal aging. As we discussed earlier, their balance is often altered, and their sensory changes are all playing a huge factor in increasing their risk for fall. On the bottom right hand of the slide, you'll see a picture I included of this safety mechanism called a life alert. And there's different variations, but that's just one brand. But what it does is it basically is a necklace that the client can wear. And that way, if they fall or they need assistance, they can press the button in the middle of it. And it would send an alert out to a company that would then send people to come check on them. So if someone falls and they were home alone, something like this could help them to get help quicker than laying on the floor for days until somebody finds them. Driving can be another safety risk. Again, think about their typical aging changes. So they've, had decreases in sight and hearing and an increase in glare that they see. They also have delayed reflexes. So if a car pulls out in front of them and they need to stop quickly and put their brakes on and their reflexes are delayed, this can really be a recipe for disaster. We also worry about those with dementia getting lost. The top right photo on your slide shows a tracker that someone with the later stages of dementia can wear. This could go on a wrist or an ankle. It is basically a device that is worn, so if the person were to get lost, the police have the ability to track their location and find them and bring them back home, because with dementia, they often forget objects and people they know. So this is just another safety mechanism to help keep this population safe. All right, moving on to medication safety and polypharmacy. So polypharmacy is defined as at least 6 medications that the client is taking at the same time. The average elderly client takes 6 prescription medications plus over-the-counter medications combined. So a lot of elderly clients do have polypharmacy going on, and they are at risk for using potentially inappropriate medications. The elderly clients, again, thinking about their normal body changes that they're going through, it can prove to be difficult for them to take their medication at the right time, using the right form and the right dose. Sometimes they don't have access to refill the medications. If they can no longer drive, they may have to rely on the pharmacy having a service to deliver it to their home if they don't have family members to help them. Opening the bottles with the child safety locks can be extremely difficult. So in a lot of cases, they'll need their medications in an easy open container. And because of the difficulty with their sight changes, it's also often hard for them to read the labels, the safety labels, and understand all of the side effects or when to let their doctor know if they're having a side effect. These clients are at risk for acute confusion, delirium, and depression related to the side effects from mixing all of their medications. All right, protection from elder abuse. So just like the pediatric population, the elderly are at high risk for abuse. And this is because they're both vulnerable populations that often need assistance with their ADLs. So because of that, we see a variety of forms of abuse in the elderly population. They are listed here on the slide, from battering to inappropriate use of restraints. You will see the picture on the left-hand side of the slide is a barco chair with a tabletop restraint on top. So unfortunately, a common occurrence you may or may not see is in a long-term care facility. The client will get up and get ready for the day, and often the caretaker will put them in a barco chair, and because of their high fall risk and sometimes confusion or delirium that's going on, the caretaker tries to increase their safety, and they'll put the tabletop restraint in front of them and leave them there for sometimes extended periods of time. And of course, as with any restraint, there has to be certain safety mechanisms and assessments that go along with them. In addition to that, there is force feeding or physical punishment, non-consensual sexual contact that unfortunately it really does happen. Treating an elderly person like an infant. That's having a lack of respect, and this is part of ageism almost, which we're going to discuss later. Enforcing social isolation. So not letting them come out of their rooms after they are up and ready, demeaning them, belittling them, or neglecting them, or simply just not caring for them or assisting them with their ADLs. Abandonment or financial exploitation. So convincing them to give up their years of work and financial stability. They're a vulnerable population, and they can be very easy to manipulate sometimes. Unfortunately, when there's a vulnerable population, there are people who try to take advantage of them. Okay, psychosocial transition. So this is a large transition, just like any other developmental stage. This is a transition not just biologically for them, but also socially and culturally. They went from a very independent population of regular young adults and even older adults to a more dependent role. They often need more help with basic ADLs, and as you can imagine, that can take a toll on someone psychosocially. The theorist Erickson still comes into play here. The stage here is integrity versus despair. This stage starts at 60 years and goes until death. And it notes that there is strength of wisdom from experience as a positivity for this stage. I touched on ageism briefly. Basically, ageism is a discrimination. They have less respect and consideration with the elderly. So it's when they take the elderly group and criticize them and demean them just based on their age alone. Ashton Applewhite is a huge supporter of the elderly. He works very hard with trying to fight ageism. I actually have his quote here, and I will read it for you. Like racism and sexism, ageism serves as a social and economic purpose to legitimize and sustain inequalities between groups. It's not about how we look, it's about how people in power assign meaning to how we look. So there's also a video here that is an example of ageism from Saturday Night Live. They're obviously trying to make it funny and make a joke of it, of the situation. But I think in no way would SNL take a group and scrutinize and make fun of them like they did here. It is unfortunately pretty normal in our society. Even in elementary schools, you may see kids dress up as like an elderly person on the 100th day of school, and the kids will often mimic them or act like them. So it's easy for them to see it as normal to scrutinize and have ageism in their society. Depression is also listed on here because it's a very common problem with the geriatric population. But again, it's not a normal part of aging, just like dementia is not a normal part of aging. It is a symptom of their transition and lack of respect or having difficulty with these changes socially or culturally. Aging in place and alternatives. So as this population ages, their needs are going to shift. So there are some different opportunities for them to age in place, and there's also different alternatives to aging in place. There are retirement communities, assisted living facilities, and nursing care facilities, or what we know them as nursing homes, that we will go over in this portion of the voiceover. We're starting with retirement communities. So the first group include natural occurring retirement communities. So basically, this is called aging in place, and it happens when there is a neighborhood or small community where the people stay there, who live there in these homes or apartments, and they all age at the same time. One neighbor may have assistants come in or may have Meals on Wheels or some other kind of service, and over time, they all kind of share and communicate and support each other. It becomes a retirement community all on its own because the people living there bring it to them. Then there is the retirement community where there is the person moving from their original home to this community. It is built to accommodate their needs, so it is often a single level, or if it's not a single level, it may be an apartment complex, but the unit itself doesn't have stairs, and it is set up to be smaller typically. So they are downsizing, but they also have upkeep services. And what I mean by upkeep is they don't have to worry about mowing their lawn. Usually electricity and heating bills are included. So that way it is less for the elderly client to have to keep up with paying bills and taking care of property maintenance. The next is continuing care retirement communities. And there's a wide range of living accommodations with this community. It can be very campus-like. Sometimes there will be like a wing that will have a different level of care that is there. There's also often extracurricular activities like exercising, crafts, music, and there's also nursing care for certain wings that may need it. We are now moving on to alternatives to aging in place. So the first is assisted living. This is when they either have services provided or services coordinated through them. There is 24-hour supervision and assistance. The goal of assisted living is to maximize the dignity, autonomy, privacy, independence, and safety of the elderly person. Then there is the nursing care facilities, commonly called nursing homes. This is where we have skilled and unskilled nursing personnel working with the adults and the older adults. So it doesn't have to be just the elderly population in the nursing homes. It can be people who are younger as well, and it serves those with disabilities and those that have a higher acuity of care. So an example of this is St. Margaret Center. It is a nursing home or a long-term care facility, a skilled nursing facility. And as you guys know, if you've been there or if you haven't been there yet, you will be going. It's basically skilled nursing, and it's not necessarily for older adults. A lot of them are actually pediatric patients, or pediatric residents, I should say. About half of the clients within a nursing home have some sort of dementia. There are actually some nursing homes or facilities that actually have units that are specific to dementia. As an LPN, I worked at a nursing facility that actually had a unit that was specifically for patients or residents that had dementia and memory issues. So it was more of a memory care unit. Okay, so I'm sure this chart looks pretty familiar to you. It's another CDC vaccination chart, but this is for the age group of 19 and older. The two vaccines that we will discuss are circled on the chart, and those are the ones that will protect against shingles. As you saw on the previous slide, the zoster vaccination actually has two different types. There is the RZV, which is the recumbent vaccine, and it is given in 2 doses. The trade name is called Shingrix, and this is given intramuscularly. The other vaccine is the live vaccine, the ZVL, and this is given in a 1-dose subcutaneous injection. This is not the preferred method because it is a live vaccine. It's also called Zostavax. Just know that there's specific guidelines for administering these vaccinations, and if you look on the left-hand side of the slide, it explains the interval between vaccinations as well. There is also a CDC link if you'd like to look at that for the full vaccination schedule. So that concludes our geriatrics voiceover. If you have any questions at all, please feel free to email me.